We have some change in the program. The first speaker will be Dr. Heywood because he has to leave early. And I'm going to invite Dr. Kirit Patel, who is our Chief of Cardiology, to introduce Dr. Heywood.
Well, I want to welcome everybody for this Clinic Day meeting today. And it's my great pleasure to introduce the first speaker, Dr. Thomas Heywood. Dr. Heywood has been in practice since 1987. He is fellowship trained in cardiovascular disease and specializes in treating patients with congestive heart failure and those with advanced heart failure. Dr. Heywood joined the Scripps Clinic in 2005 to serve as the Director of Heart Failure Recovery and Research Program in the Division of Cardiology. In addition to his clinical practice, he conducts research on heart failure, including renal dysfunction in heart failure, implanted heart failure monitors, and efforts to improve outcome of patients. In 2012, he became the medical director of the left ventricular assist device, the LVAD program, which implants small pumps in those with end-stage renal heart failure. He supervises the delivery of heart failure services for all 5 Scripps hospitals in addition to that. In addition, he is a co-director of the Pulmonary Hypertension Clinic. He is internationally recognized expert in heart failure and has authored more than 80 publications and lectured throughout the world on state-of-the-art cardiomyopathy treatment. In 2011, he published a book with John Burnett of the Mayo Clinic entitled The Cardiorenal Syndrome, which is his topic today. From 1992 to 2005, Dr. Heywood directed the prestigious cardiomyopathy and cardiac transplant services at the Loma Linda International Heart Institute, Loma Linda in California. He's board certified in internal medicine, advanced heart failure, transplant cardiology, National Board of Echocardiography, Adult Comprehensive Echocardiography, Cardiovascular Diseases, and Internal Medicine. Dr. Heywood, please come to the podium.
We'll get you up here. See, this is it, right?
Yep. There we go.
Okay, slideshow. And you can
Thank you.
go from there. Thank you.
Well, thank you very much for the privilege to present to you today. This is clearly a very remarkable, I don't think I've been to a program that's the 58th program of that. That shows remarkable commitment to education, which we all have to do. This is the place where I get to work in La Jolla. Although we've kind of outgrown this and we have to move a little bit, so I'm going to lose my ocean view soon. But I was thinking as the chaplain was speaking, we learn so much from our patients when we listen to them and when they have problems. And the essence of a good physician is compassion. What does compassion mean? Compassion means to suffer with. And if we suffer with our patients and we learn from them and they get better and we get better. So it's a win-win situation. So this talk has really grown out of suffering with patients who have this horrible syndrome called the cardiorenal syndrome. I'll tell you what it is in a minute. I don't profess to know everything about it, but what this is kind of a practical approach that you'll be able to help some of the people and at least understand it better in some of the people. And we still have to learn. There's a lot that we have to learn. So let's see, how do I advance the slides? I think enter, good. These are my disclosures. So let's talk about a definition. There are several definitions of this. One is worsening renal function, increase in creatinine or BUN while we're treating acute decompensated heart failure. And a little bit is okay, but too much is bad. It can be difficulty in diuresing people with worsening renal function. You know, they're fluid overloaded, but we just can't get the fluid off. And that can be very frustrating and very painful for the patient. A special form is patients that are intolerant of ACE inhibitors. That's important to recognize. When you stop an ACE inhibitor, that's a sentinel moment in the patient's life with heart failure. And finally, many patients have both cardiac disease and renal disease. And how do we treat the nexus of those two very serious problems? I was privileged to be part of the ADHERE database. That was about 10 years ago now, maybe a little bit more, where we looked at over 100,000 patients with heart failure. And we asked a simple question: how many of them have renal dysfunction? And when we calculated their GFR and put them into the chronic kidney disease stages 1 through 5, we were a little bit surprised to learn that over 2/3 of them had stage 3 or higher chronic kidney disease. So it's not the unusual person that has renal dysfunction with heart failure, it's the typical person that has renal dysfunction with heart failure. Maybe not surprising that they end up in the hospital with heart failure because their kidneys aren't working as well as they should, and they can't process salt and water the way they should. So it's a very common problem, and that's perhaps one of the reasons you might be interested in this lecture today. The other thing that we learned from ADHERE, we put all the clinical characteristics of the patients into a supercomputer and ask a simple question using the card analysis. What are the predictors of mortality when patients come to the emergency room with heart failure? And we thought there'd be ejection fraction and how many coronaries were involved, but that wasn't the case. The number one predictor of a bad outcome when you were in the emergency room was your BUN. If you had a BUN over 43, your mortality was 8% at least, in the hospital, not in the next 6 months or a year, but in the hospital, 8%. Typical heart failure mortality is 3 or 4%, so that's double the expected mortality. The next predictor was your blood pressure. If you had low blood pressure, your mortality doubled. And if your creatinine was high on top of that, then your mortality went up to 20%. On the other hand, if your BUN was normal and your creatinine was normal, then your mortality was only 2%. So a tenfold difference in mortality by knowing 3 things in the emergency department about the patient, and 2 of them have to do with the kidney. Probably the third one does too, because if you have low blood pressure, the kidney isn't very happy. So nothing to do with ejection fraction, nothing to do with what your arteries look like, but everything to do with how your kidney's responding to heart failure. This was quite revolutionary. So that's a little bit about the epidemiology. It's common and it's predictive of mortality. So why is renal dysfunction abnormal in heart failure? So Cody and his colleagues did this small but I think important trial in heart failure where they grouped patients with hemodynamics in heart failure. And so if you were in the blue group, you had good hemodynamics. If you were in the green group, you were a little bit worse. And obviously, if you're in the red group, you have the worst hemodynamics, low cardiac output, high filling pressures, et cetera. And then they did something very unusual. They measured renal blood flow. And as you can imagine, as the cardiac index went down with each of these stages, the renal blood flow went down as well. And the renal vascular resistance went down, not surprising. But what was surprising, or what was important to learn, was the kidney can regulate to a degree, so that the middle group, even though their cardiac index was low, the GFR was absolutely normal. Whereas once you got a cardiac index below about 1.5, then GFR was impaired. And a marker for that was actually an increase in BUN. So now the problem with BUN is it's not specific for low renal blood flow, but one of the causes for increased BUN in heart failure can be low cardiac output. So we saw from the ADHERE database that BUN was important. We saw from Cody's data that BUN's, why does the BUN go up? What does it mean when it goes up in heart failure? Well, it's poor renal perfusion. Creatinine is filtered but not reabsorbed. BUN is reabsorbed with water in low flow states. Thus, it's a marker. So more BUN gets reabsorbed when there's poor perfusion of the kidney. But it also goes up when you've lost nephrons. So there can be several competing reasons why the BUN goes up. But for whatever reason that the BUN goes up, it's a bad thing ultimately. Blood in the gut can make BUN go up, but that happens rarely, except if you have an LVAD. But so it's consistently found to be a marker of worse prognosis. It's a darn good and cheap biomarker. I think one of the things you could go away from here is if your patient's BUN is over 45 or 50, that's a bad prognostic sign for the patient, and that patient is in a different prognostic group with heart failure. So low cardiac index can be a cause. The other cause is high central venous pressure. This is data from Firth, now almost 30 years old now, where he took an animal model and just raised the central venous pressure. And with that, as central venous pressure got into about the 20 range, GFR really fell. What was important about that was that that's reversible. If you can reverse the high central venous pressure, then GFR will improve. And there's been several other data sets that have shown this. Another marker, these were swine that were instrumented. They constricted the renal vein, and GFR plummeted with constriction of the renal vein. And also, interestingly, aldosterone levels and renin levels go up. So part of the neurohormonal storm that we see in heart failure, it's not just low blood pressure, but it's congestion of the kidney causes activation of the renin-angiotensin system. And we can go into this vicious spiral of sodium retention and worse heart failure as fluid retention goes up. So as fluid retention goes up, the body tries to retain fluid more, and that's a huge problem. The other thing about the kidney is it has a capsule. And this makes it, this can cause problems with the kidney. This is a very interesting experiment where they took animals and caused ATN by clamping the aorta. And then they instrumented both kidneys. One of the kidneys, they actually took off the renal capsule, and the other, they left the renal capsule on. The kidney where the capsule was removed actually did much better. So part of the problem with high central venous pressures is that it can cause a compartment syndrome in the kidney. The trauma surgeons know this. Sometimes they have to open the abdomen when there's a severe abdominal injury. But so the high central venous pressures cause neurohormonal activation, and they actually cause a compartment syndrome in the kidney. Fortunately, you have Dr. Tang here. We've learned a lot about the cardiorenal syndrome from Cleveland Clinic, and especially Wilfred Mullins when he was there as a fellow. Did you have many other fellows that were as good as him? He seemed like an incredibly prolific fellow, a very smart guy. Anyway, he looked at their data set and found that venous congestion was a very important cause of worsening renal function and heart failure. That actually a high central venous pressure was the #1 predictor of worsening renal function. He found that low cardiac index wasn't as important. I don't think it's not important. I think some patients have, the predominant problem is high central venous pressure. Other patients, if you have a very, very low cardiac index, that's a problem as well. The point of this is not all patients are the same, and you have to try to decide what's going on with the patient. Going in line with this compartment syndrome, they also did this clever thing of instrumenting a Foley catheter where you could get pressures within inside the bladder. And so you could measure intra-abdominal pressures. And high intra-abdominal pressures apparently caused problems with the kidney as well, and were correlated with worsening renal function as abdominal pressures were high. So patients who have a lot of ascites, who have abdominal distension, this is one of the complaints that patients have. In fact, there's a new symptom that's been described called bendemia or bendopnea, where you bend over and you get shorter breath. Patients have been complaining this for years, but we didn't really have a name for it. Now we have a name for it. It's because of central congestion within the abdominal cavity, and those pressures can affect the kidney apparently and cause renal dysfunction. So some patients, when you do a paracentesis, their renal function can actually improve as you reduce intra-abdominal pressures. So those are the kind of the pathophysiology, poor renal perfusion, low blood pressure, high venous pressure within the kidney, high intra-abdominal pressures. So you know, we all go on rounds, and as poor medical students, we all were traumatized during rounds, and people would ask us the 10 different things, and we could never remember it because we were asleep, and we were nervous because a really old guy is picking on us, and we're not sure what we're going to do. But one of the ways, you know, we don't deal with groups of patients. We deal with one patient at a time, and usually each patient has a unique set of problems that contribute to what's making them sick and what's putting them into the hospital. So we have to have a way of interrogating ourselves and asking ourselves questions about the patients so that we can create a path so that they can get better. So these are the questions that I've come up with that help me organize my thinking about what's going on in a patient. So the first question I ask myself when I'm called to see a patient with worsening renal function, and the hospitalists don't call me if everybody's peeing and their creatinine's 1, they don't call me. They call me when the creatinine's going up and they're not peeing. So is the blood pressure adequate for renal perfusion? That's an important question. That's key. If the blood pressure is 50, we have to fix that first. I think that's self-evident. What's the volume status? That's a much harder question. One, because sometimes physicians aren't as adept at determining volume status, so I'll show you some clues about that. What's the cardiac output in SVR? Now, that's really hard. Now, we don't always have to know that, but sometimes we do have to know that. And we don't put in swans like we used to. I think, you know, we used to put in too many swans, and now I think we put in too few swans, and so I think we have to put in a few more swans than we do. And then SVR, well, that's a hard one. That's mean arterial pressure minus the right atrial pressure divided by the cardiac output. How in the world am I going to get that number at the bedside? And finally, is there intrinsic renal disease? Now, I'm going to show you by answering these questions that it will help you figure out what type of cardiorenal syndrome you're dealing with and then what to do about it. So, the first type of the cardiorenal syndrome, hypovolemic cardiorenal syndrome. This is the one I hope to see. This is somebody that's over-diuresed, or they came into the hospital because they have nausea and vomiting, they have volume loss, and their creatinine's going up. They're absolutely dry. How do we know they're dry? Because their neck veins are flat. Now, if you really can't tell, you can quick get an echo and look at their IVC. I think we're doing that more and more commonly now. There's handheld echoes. I think within a few years, the expensive part of the handheld echo is the probe, but I understand that they can make the probe now with 3D printers, and so the probes is going to go from a couple of $1,000s to $10, and then you'll just hook up the probe to your iPhone, and then you'll have an echo machine that you'll have in your pocket. So you can look at the IVC, and if it's flat, then you give fluid. Now, there's often a reluctance to give volume to heart failure patients because you don't want to put them into heart failure. I suppose that's appropriate, but if the blood pressure is low and they're dry and their neck veins are flat and their creatinine is going up, just give volume. You watch the patient, be careful, but giving them a liter, they might need 2 liters, but that can be life-saving to the patient because you protect their kidney. This is what I like to see. I hope that's what's wrong with them. It is maybe 5% of the time, but it's the absolute easiest thing to fix. So we stop their diuretics for a while and give them fluids. So the other thing, us doctors can cause the cardiorenal syndrome. We make patients dry. How do we treat heart failure? We give them diuretics, maybe we ultrafiltrate them once in a while. We pull volume. Where does that volume come from? It comes from the plasma volume, and there's about 5 liters in that space. Now that space would be quickly depleted if it wasn't refilled, and that extra volume comes from the extracellular space. And when patients come in with edema, ascites, et cetera, pleural effusions, there's lots of extra water in the extracellular space. So when they're putting out 300 or 400 cc's of urine an hour, they don't deplete their vascular volume because the plasma is being refilled. And that's great. But the problem is that after a while, that extracellular volume is depleted and it doesn't exist anymore. And so if you continue to diurese them, then the creatinine goes up and up and up, and people get over-diuresed. So diuretics may be wonderful on Monday and great on Tuesday and fine on Wednesday, but a disaster on Thursday. So we have to learn when the patient's passed from hypervolemia to euvolemia, and they're starting to get hypovolemic. So how do we judge when they become euvolemic? And that's where neck veins come in. So I have a movie about how we look at neck veins, and this is the secret of all heart failure doctors, is that we look at the neck veins. So you put the patient up about 30 degrees, and you turn their head to the side, and you look at their neck veins. And I think you can see the top of his neck vein near the angle of his jaw. And so you mark where you see that, then you get out your ruler, and you measure how high that is above the second intercostal space. And here it's about 12 or 13, as I remember, yes. So the right atrium is 5 centimeters below that, so you add 5 to that number. So his jugular venous pressure is 17 or 18 centimeters water. Anytime that's over 7, the patient's volume overloaded, okay? Anytime it's more than 2 centimeters. Now, sometimes you can't see the neck veins well. Do you see how much better you can see them now? That's because I have a flashlight, and I'm shining the light from behind the neck. Now, we used to use those silly little pen lights that the drug reps used to give us. Those were practically worthless. What you need to do is go to the hardware store and get a nice LED flashlight that has about 8 bulbs in it. It costs about $8. You can see neck veins like you never saw before. It's spectacular to look at neck veins. So this is a lost art. It needs to be recreated. So you can go to Google and put in Heywood neck vein video, and you can watch the video again. And it's on YouTube. And I have a lecture about how to do neck veins. This is the silent one. I have one lecture that tells you about the importance of doing neck veins. Now, my kids are very mad at me because I have more hits on YouTube than any of them. I have almost 250,000 hits on YouTube from this video. Now, I'd have more, but the Russians stole my neck vein video. If you go on Google and you put in this one, you'll see the same video, but it'll say Russian medical team on it. And they have about 80,000 hits. And I used to be mad about it, but then I kind of got over it. I said, look, more people are seeing it, that's good. And 2, if they'll steal the Ukraine, they'll steal your neck vein video. So the patient is euvolemic when their jugular venous pressure is less than 7 centimeters of water and their renal function is stable. The neck veins are great at telling you when people are too wet, but you can have normal neck veins and be too dry when the BO and creatinine is going way up. So the neck veins are the first thing that go up when people become volume overloaded, usually, and the last thing that goes away when they become euvolemic. So they could have no edema and they're in the hospital, but their neck veins are still up. They still need to be diuresed more. And high neck veins without edema, without abdominal fluid, about 5 to 7 pounds of water extra. The second part of the neck vein exam is you put your hand in the abdomen and press in firmly. You can have normal neck veins, but if they go up to the jaw when you press in, that's called an abdominal jugular reflux. And that's the most sensitive test for fluid overload. You can have normal neck veins, but if they go up and stay when you push. Now, everybody's neck veins go up when you press on their abdomen because they valsalva. So you have to hold pressure for about 15 seconds and wait for them to start breathing and see if they stay up with them breathing or if they go down when they start breathing. If they don't start breathing again, call a code. But normally the neck veins will come down in a normal person but stay up in an abnormal person. But if you ask any heart failure doctor, the neck veins are the secret sauce of heart failure. That's the thing that we look at rather than RALs and S3s and all that stuff. So, obviously, we're walking a fine line here. We're trying to diurese people, but we don't want their renal function to go up. Now, this has been an evolving field. About 8 or 9 years ago, we got very stressed out because we learned that if their creatinine went up, patients did worse. And so we were very concerned, we don't want the creatinine to go up at all. Creatinine's starting to go up, so we're going to stop their ACE inhibitor. But that turned out to be a little bit wrong. We don't want to kill the kidneys, but we don't want to get completely obsessive about the creatinine. So this is work by John Testani, very clever young man, Dr. Testani. Now, when you do an NIH trial, the government pays for your data, right? So the data belongs to the people of the United States of America. So all the data is on a website. So he took a trial that was many years old, where people who had heart failure got a swan put in, And he took that trial was negative, but he took the data and he massaged it. And what he did was divide patients who had the SWAN into two groups. One group were hemoconcentrated. That means their plasma volume was shrunk while they were being diuresed. How did he know that? Because their hematocrit and their total protein in their serum went up between when they came into the hospital and when they went home. The only way your hematocrit would go up is if you got hemoconcentrated, unless you got a blood transfusion. Same thing with total protein. Nobody gets a total protein transfusion in the hospital. It makes sense that people that were hemoconcentrated had better hemodynamics. Their right atrial pressure was lower. Their pulmonary artery pressure was lower. Their wedge pressure was lower. It also makes sense that their GFR went down, because they were drier. And I think most of us would have predicted that if your GFR went down, you'd get worse. But what was surprising was that those patients actually got better. They did better. They survived better. So my definition of a great study is something that changes my clinical practice. And so this study changed my clinical practice. I used to preach, and I say preach advisedly because sometimes you preach when you're based on faith rather than knowledge. So I'm a religious person. I believe in faith, but in scientific matters we should act on knowledge rather than faith. And so I believed that going home a little bit wet was better than going home a little bit too dry. But now I've changed my mind. I think it's better to go home a little bit too dry than a little bit too wet. So what does that mean? That means if their creatinine was 1.5 when they came into the hospital and their creatinine is 1.7 when they leave, but they're euvolemic and they look good, that's okay. Look at the patient, and I don't want their creatinine to be 3, but if it went up 10 or 15%, that's okay. So you can be too wet. You could be too dry. We've talked about that, and sometimes that happens because of us over-diuresing somebody, and sometimes it happens because people have nausea and vomiting. Or you can be too wet and have neck veins that look like ropes. And we talked about this. So this is high central venous pressure that causes renal dysfunction. This is probably one of the most common causes of the cardiorenal syndrome that you'll see. And we used to have interminable bedside discussions about this. What should we do? The creatinine's going up. Should we hold the diuretics? People used to hold the diuretics all the time. They're intravascularly volume depleted. That's why the creatinine's going up. But you can't be intravascularly volume depleted when your neck veins look like that. Your vascular volume is hugely, it's not enlarged, but your vascular volume is normal or increased. And your central venous pressure is very high. And the reason your creatinine is going up is because your kidney is being stressed by high central venous pressure. You have low blood pressure, high central venous pressure. There isn't much perfusion pressure across the kidney. So the treatment for this is more diuretic, not less diuretic. So that gets us to the question, how do we give diuretics in the hospital? Fortunately, the Heart Failure Network has given us a lot of good answers about that of late because they're doing these very practical trials answering very important day-to-day questions about heart failure. And this trial, the dose trial that was in the New England Journal, asked the question, how much diuretic should we give somebody that's volume overloaded in the hospital? So they divided patients into 3 groups. You either got high-dose diuretics or low-dose diuretics. You either got them as a bolus or you got them continuous, and to try to see the difference. So for example, if you were on 80 of Lasix at home, if you were randomized to the high-dose group, you got 200, 2.5 times 80 is 200, and you got it continuously in group A. So you got about 7 milligrams of Lasix an hour. If you got to the high dose but bolus, you got 100 twice a day, every 12 hours. If you got randomized to the low dose continuous, if you're on 80 at home, you got 80 in the hospital. You got about 3 milligrams an hour. Or if the D group, you got 40 twice a day. You got 80 a day. So the answer to the study was a resounding, if you got more diuretics, you peed more. So a lot of people thought they knew that, but there was a lot of discussion about that, but now we kind of know the answer to that question. And the other answer was there wasn't a penalty to giving 2.5 times the diuretic dose. Your renal function didn't worsen. So this was a great study. It did change my practice. I give higher doses of diuretics than I used to in the hospital when people are volume overloaded. The other important study was the CARESS trial, also in the New England Journal. These studies ask simple questions, but sometimes the simple questions are the best. So this really is key to this talk. What do you do with patients who have worsening renal function but are still fluid overloaded? Should you give them more diuretics, although the diuretics don't seem to be working all that well, or should you ultrafiltrate them? What's the best thing to do? So at 96 hours, which was the endpoint of the study, whether you ultrafiltrated them or you gave them more diuretics, it didn't matter. They both lost about 12 pounds. So what's going on here? You're enrolling patients in a study because they have worsening renal function. You're diuresing them, but it's not working. All of a sudden, now you can diurese them. What's the difference? So I looked all through the paper, trying to find out what was going on. And actually, the patients that got ultrafiltrated, their creatinine went up a little bit more. So diuretics seemed to be fine, but nowhere in the paper did they tell you how much diuretic that they gave. There was one cryptic remark: please see online appendix. So in my mind, the most important part of the trial wasn't in the publication, it was in the appendix that was online. And this was the recipe, if you will, of how they gave diuretics to patients that had worsening renal function and were fluid overloaded. So if you were putting out a lot of urine, then they said just continue what you're doing. But if your urine output was low, they said see table. So what does the table say? So if you were on 80 a day or less, then you got 40 milligrams IV plus 5 milligrams an hour. So 5 milligrams an hour is 120 plus 80, 200 milligrams a day, right? That's a pretty good dose of Lasix. If you're on 80 plus 1 or to 160, you got 80, but then you got 10 milligrams an hour. So that's 240 plus 80, 320 milligrams of Lasix a day. Now that's starting to get up fairly high doses of Lasix, plus metolazone. If you're on over 160 a day, you got 80 plus 20 milligrams an hour. That's 480 plus 80, 560 milligrams of Lasix a day, plus 5 of metolazone twice a day. Now we're getting to industrial doses of diuretics. If you're over 240 a day, you got 80 plus 30 milligrams a day, 720 plus 800 milligrams of Lasix a day, plus 5 of metolazone twice a day. I really rarely used these types of doses before this came out. I'm starting to use higher doses, but I think the point from these two trials is that oftentimes we weren't using high enough doses of diuretics to patients that continue. Obviously, we have to be careful with this. If you're going to give, remember from the dose trial, you could give continuous or bolus. You don't want to give 800 milligrams of Lasix as a bolus. That's a bad idea. So if you're going to give high dose, you really have to give that continuously. And you have to monitor the patient to make sure you don't over-diurese them with that. But I think the lessons from this, and what changed my practice, is that when patients continue to be volume overloaded, even though their creatinine's elevated, if I think it's because of high central venous pressure, then I need to get that fluid off, either with diuretics or ultrafiltration. Why does metolazone work? Loop diuretics work by blocking chloride transport out of the thick ascending limb of Henle, so sodium gets excreted, and it goes into the distal tubule. When you first give your first dose of a loop diuretic, they urinate like crazy, because the distal tubular cells can't reabsorb it. But over time, at least in animals, those distal tubular cells hypertrophy, and they can reabsorb a lot more sodium and chloride. We think this is part of the way that patients become diuretic resistant. So by giving hydrochlorothiazide or metolazone, we can block those distal tubular cells and restore diuretic responsiveness. So it makes sense in the hospital to give a distal tubular diuretic. You do have to be careful in outpatients. I'm very cautious about giving metolazone because patients can really diurese in an uncontrollable fashion, but sometimes we have to do it. But it is safer, I think, in the hospital. So there are some differences in diuretics. Furosemide has very variable absorption. That's not so true with bumetanide and torsemide. Torsemide has some very nice characteristics about it. So when patients aren't responding orally to furosemide, we often switch them to bumetanide and torsemide, and that seems to work better in some patients. It'd be nice if we had some better biomarkers for the kidney that tell us that something bad is going with the kidney. In Europe, they have NGAL, which is a protein that's made in the proximal tubule and gets reabsorbed. When the proximal tubule is injured, it doesn't get reabsorbed, so NGAL goes out into the kidney, and you can tell that ATN is going on very quickly by measuring NGAL levels in the urine. This would kind of be the nephrologist's troponin. It's not available quite yet in the United States. So we've talked about being too dry and too wet. Patients can be very vasoconstricted. This doesn't happen as much anymore because of ACE inhibitors and vasodilators, but this was a classic cause of worsening renal function in the past. You get intense vasoconstriction, arterial constriction, causes low cardiac output, and you get into this vicious cycle where the kidney is hypoperfused. And so we had to give vasodilators to patients. Nitroprusside or ACE inhibitors can be very useful in these patients if the blood pressure is okay. Sometimes you need to add an inotrope to support the blood pressure when you're giving an ACE inhibitor. But on the physical exam, these people have ice-cold feet, and that's a marker for intense vasoconstriction. Swan-Ganz catheter, if it's put in, if it's needed in these situations, can tell you that the SVR is high, over 2,000. And by just vasodilating the patient and cutting their SVR from 2,000 to 1,000, the cardiac output doubles and the renal problems can go away. Sometimes the SVR is normal and the cardiac output is just too low to support renal perfusion of the kidney. So this is the bad pump syndrome. This is the fourth cause of the cardiorenal syndrome. You have a normal SVR but low cardiac output and low blood pressure. It's due to inadequate renal perfusion, and here inotropes, pressors, balloon pump, and even an LVAD may be necessary to reverse multi-organ failure that's starting to develop. Now, there's been a lot of now I'm talking about using dopamine in some of these patients. Dopamine has had a long and storied history in cardiology. When I trained, we talked about renal dose dopamine. We could use 2 to 3 micrograms per kilogram per minute of dopamine to dilate the renal arteries, and we thought that this would make renal perfusion better and help the patients. And then a number of renal studies came out where they randomized people to dopamine and it didn't make any difference. Now the problem, I think, was that what the nephrologists were studying was somewhat different than what we were doing in cardiology. The nephrologists were studying ATN and sepsis, and I think in those cases, dopamine isn't very useful. But we were giving dopamine to people who weren't in ATN yet, and we were trying to prevent ATN, and I think that's a different situation. So my good friend Uriel Khayyam did this really clever trial where he took patients with heart failure and took them to the cath lab and actually measured their renal blood flow, and then gave them dopamine. And he measured their cardiac output and renal blood flow. The bottom line is their cardiac output, and the top line is their renal blood flow, and at various doses of dopamine. And you can see at about 3 micrograms per kilogram per minute of dopamine, you get a little bit increase in cardiac output, but you get a great increase in renal blood flow. So he was actually able to prove that there is such a thing as renal dose dopamine. Now the question is, does that translate into a clinical effect? Well, there was a trial where they looked at low-dose dopamine or low-dose nasiratide in acute heart failure with renal dysfunction called the ROSE trial. 360 patients with heart failure with reduced GFR but greater than 15. They had low and normal EF patients, average EF 35%, mean blood pressure 115, evidence of volume overload, and their kidneys weren't bad. And so they got either Naseritide or dopamine. And the bottom line was that neither of those drugs helped very much. But I have some little problems with the study. The diuretic dose was the endpoint was renal, was urine output, and the people that got dopamine got less than the diuretic than the people that got placebo. So as we know that diuretic dose is important, that may have played a role. It wasn't quite statistically significant, but it was close. Also, the dopamine dose was 2 micrograms per kilogram per minute, which was a little bit lower than the optimal dose. And they actually gave it to people with normal blood pressure and normal EF too. And that's not typically who we give dopamine to. We usually give dopamine to people with low blood pressure and low ejection fraction. And you can see from the forest plot that the people who had a low EF actually, now you can't take this to the bank. This is hypothesis generating. I'm just putting out my hypothesis. The people that had a low EF actually did a little bit better with dopamine compared to those with a normal EF. And the people with low blood pressure did better too. So this paper hasn't changed my practice. I still use dopamine in selected cases. I don't give it to everybody, but I think that there's some reason to give this in patients with very marginal blood pressures and suspected poor renal perfusion. Now, the best way to treat this is if you can put in an LVAD, if it's an appropriate candidate. You can take patients with quite bad renal dysfunction that's reversible. It hasn't become irreversible yet, and you can make creatinine get much better with an LVAD. And one of the, I think, markers for people that need an LVAD is that they have worsening renal function that improves with inotropes, but you can't give them inotropes forever, and an LVAD will help correct this in those patients that have very low cardiac index. The fifth form of cardiorenal syndrome is patients that have excessive vasodilatation. Now, we talked about excessive vasoconstriction as a problem, but too much vasodilatation is a problem. These patients have renal perfusion because the cardiac output is shunted away from the core and to the periphery. So these people, paradoxically, are warm. And if you measure their cardiac output, it's not quite so bad. It might be in the 3 to 4 range, but their blood pressure is 70. So vasodilators are a disaster for these patients. We have to stop ACE inhibitors. We have to give pressors. You have to rule out sepsis. This could be sepsis. In fact, Kanner Chatterjee called this a pseudosepsis syndrome. And we think it might actually be leakage of endotoxins or other vasoactive agents from the gut into the bloodstream in patients with advanced heart failure that may be precipitating. This is an absolute medical emergency. Unless you can correct this, these patients will die. Sometimes vasopressin helps. Donald Landry has written elegantly about this syndrome. We think it's because of opened calcium channels in the arteriolars of the small resistance blood vessels in the circulatory system, so that potassium leaks out, hyperpolarizes the cell, and leads to vasodilatation that can be quite difficult to counteract, even with norepinephrine. He did show in this study of LVAD patients that giving vasopressin did improve blood pressure and reduce the need for norepinephrine. So vasopressin can reverse this in some situations. It can promote myocardial ischemia, so you have to be careful about it as well. Since we're talking about vasodilators, I wanted to talk about ACE inhibitors. There's really a complex role, a lot of discussion about ACE inhibitors with renal dysfunction. So on the one hand, ACE inhibitors are your great friend. They can improve cardiac output in some patients. They obviously make people live longer. But sometimes the ACE inhibitors lower blood pressure to the point where effective renal perfusion is really impaired. The ACE inhibitors have an interesting effect on the kidneys. So on the glomerulus on the left, this is somebody with heart failure. You see their efferent arteriole is very constricted. Angiotensin II is doing this, and that maintains GFR in that glomerulus. When you give an ACE inhibitor, you see the efferent arteriole is very dilated. It's because the ACE inhibitors block the angiotensin II. The pressure in the glomerulus goes down and the GFR goes down. So it's a normal effect of ACE inhibitors that your GFR drops a little bit when you give them. So the creatinine might go from 1.4 to 1.6. That's okay. There's no prognostic penalty for that. Actually, patients with renal dysfunction with an ACE inhibitor do as well as patients without renal dysfunction with an ACE inhibitor. Now, you can't let the creatinine triple, but a 20% increase or so is not a problem. So sometimes ACE inhibitors are stopped inappropriately because the creatinine went up a little bit, or they're concerned about blood pressure. And we don't want patients to faint, but if they're not fainting, you have to ask yourself, is the patient symptomatic or are you symptomatic about the blood pressure? So you should treat it when the patient's symptomatic. If you stop an ACE inhibitor, this is data from Lynn Stevenson, 50% mortality at 12 months. So it's a sentinel event to stop an ACE. Sometimes we have to, but notice that the patient's entering end-stage heart failure if they can't tolerate an ACE inhibitor with heart failure and they need it. Great paper on this, renal considerations for ACE therapy. They have a great quote, although there is no serum creatinine per se that contraindicates ACE therapy. So just because the creatinine's 2 doesn't mean you can't use an ACE inhibitor. You can, but you have to be careful. The greater increases occur when the creatinine's higher. So what do I do when somebody's EF's 20% and their creatinine's 1.9 and I think they need an ACE inhibitor? I start low and go slow. And you check renal function frequently to make sure the kidneys don't sky out, the blood pressure doesn't drop precipitously. Try to add the ACE inhibitor when they're a little bit wet rather than they're too dry. That can help as well. But even though the creatinine went from 1.9 to 2.1, I would still continue an ACE inhibitor in that patient. If it went from 1.9 to 3, there's probably renal artery stenosis, and I wouldn't. Now, the sixth cause doesn't have anything to do with the kidneys or the heart, and this is just obstructive problem, it's the kidneys that's the problem. So they have intrinsic kidney disease, they're diuretic resistant, or they have obstructive uropathy. About twice a year, I cure heart failure by putting a Foley in a patient, and so you always have to think about that. We do more bladder scans than we used to. I saw a patient about 1.5 years ago. One of the fellows was presenting him to me, and he got sent for heart failure. He had edema, but his neck veins were normal. So I didn't really think it was heart failure, but I was feeling his abdomen. He had this big mass in his abdomen. So I got out the echo, and I started looking at it. It looked like a big basketball, and I realized it was his kidney. And so we knew why he had heart failure now, so we admitted him and put a Foley, and he peed out 4 liters of urine. So poor guy. So I actually do a fair number of bladder scans in the heart failure clinic as I see worsening renal function, because this is a treatable form of the cardiorenal syndrome. There's also, but a lot of people just have diabetic nephropathy, and so their creatinine's 2, and it's not because of hypoperfusion, and it's not because their venous pressure is high, it's just because they've lost glomeruli because of their kidney disease. And they're harder to treat, and eventually they may end up on dialysis, but it's not the heart that's doing it. And as those kidney patients get worse and worse, they end up in the hospital. They don't really have the cardiorenal syndrome, they have the renal cardio syndrome, because their kidneys are so bad that they retain fluid, and it's not so much their heart, it's just that their kidneys don't work. And the nephrologists help us out all the time in those cases. So we talked about SVR and cardiac output. SVR is mean arterial pressure minus the right atrial pressure. Normal is about 1,000 to 1,200. High is 2,000, they're vasoconstricted. Low SVR is 500, they're vasodilated. So how do we get that cardiac output? Well, we put in a swan. Well, we're not supposed to put in swans anymore, right? Well, that's not quite true. The guidelines still say that we can use invasive hemodynamic monitoring for when patients are refractory to initial therapy, when we don't know about their volume status, when they're critically ill, or they have worsening renal function. So we can put in a swan for that. But I think there's something short of a swan that we often use, to kind of get us through the night when it's 11 o'clock at night. We get an echo and we look at the blood flow just before the blood's going through the aortic valve, the LV outflow tract. This is called the LV outflow tract time velocity integral. And you integrate that pressure signal and it's pressure over time. So when you integrate it, you get a distance, okay? Or velocity over time. You get a distance, and that's the stroke distance. If you knew the outflow tract area, then that distance becomes a cylinder, and it becomes the stroke volume. Typically, that area is about 3, so the quick and dirty method is to multiply that number by 3. Normally, it's 15 to 20. When it's below 10, that's bad. So when this number is below 10, then the stroke volume's 30, and even if their heart rate's 70 times 30, you have a cardiac output of 2.1 liters a minute, which can be quite low. So we use this as an estimate of their cardiac output, and we treat them according to this estimate. If they get better, fine. If they don't get better, then they get a SWAN. So this is how we measure this. One of my fellows looked at this number. I noticed that almost everybody that got an LVAD had a number below 10. And with the receiver operator curve, the bad number is actually below 9. If you have a stroke distance below 9 on the echo, 42% of those patients either died or had an LVAD within a year. So it's a bad prognostic sign. So we can get almost all the things from an echo, from a SWAN from an echo. It doesn't replace the SWAN, but in the middle of the night, it can help you decide what to do. If the patient gets better, fine. If they don't, then you don't wait too long to put in the SWAN. But the right atrial pressure can be estimated by the IVC, the pulmonary artery pressure from the TR velocity. We estimate the left atrial pressure by taking half of the PA systolic pressure. We can do the cardiac output. We can estimate the SVR. So we call this our hemodynamic echo for critically ill patients. So to sum up my talk, you can have cardiorenal syndrome from renal hypoperfusion, either hypovolemia, hypervolemia, because the central venous pressure is too high, severe pump dysfunction, hypotension, too much vasoconstriction, or too much vasodilatation. Those are the cardiorenal issues. Or you can have it because of intrinsic renal disease. And we think they have intrinsic renal disease when the cardiac output's okay, the blood pressure's okay, the central venous pressure's not that high, but they have a history of hypertension, diabetes, especially when they have protein in the urine. Always rule out obstructive uropathy. So I'm going to end on a literary note. One of my favorite, I love the Russian novelists, and Leo Tolstoy has this great first line in Anna Karenina. All happy families are all alike. All unhappy families are unhappy in their own way. Boy, is that ever true. There's endless ways that families can be unhappy, but all happy families communicate and love each other, and they're okay. But unhappy families don't communicate, and they don't love each other, and they're a disaster. All patients with compensated heart failure are alike. All patients with cardiorenal syndrome are unhappy in their own way, and it's your job to figure it out. So I'm trying to give you tools to do that. Thank you very much. Thank you.
We'll get some questions.
Sure. Okay.
Any questions for Dr. Heywood?
You showed us a picture with the big neck veins in the thorax. That patient has severe pulmonary hypertension. Does that play any role in this? Because I always wondered, what do you do about the pulmonary hypertension? You don't get any left ventricular preload in that situation. So does that play a role in how you manage this patient?
So the question is, somebody has big neck veins, they obviously have bad right heart failure, and they often have high PA pressures. Does that play a role? Yes, more and more what we have to deal with in cardiology is not just left heart failure, but right heart failure. And so our tools, we have a lot of tools for this, but I would say the biggest problem with pulmonary hypertension is that is a lack of understanding about how to deal with it. So this is a whole other talk, but I'm going to give it to you in 35 seconds. So here's pulmonary hypertension, okay? Anybody that has a mean pressure over 25 PA pressure, usually a systolic of 50 or 60. 95% of them have what we call pulmonary venous hypertension. They have pulmonary hypertension because their left atrial pressure is high, because of something wrong with the left heart. That's 95% of what we see. 5% of it is pulmonary arterial hypertension. They have a normal left atrial pressure, and the problem resides in their lungs. Scleroderma, pulmonary emboli, idiopathic, drugs, whatever, something that affecting their lungs is causing pulmonary arterial hypertension. The treatment depends on which type you have. If you have pulmonary venous hypertension, the common form, you try to reduce the left atrial pressure as much as possible, and that reduces the afterload of the RV, and that improves cardiac output. If they have pulmonary arterial hypertension, then you give them pulmonary arterial dilators like sildenafil and bosentan and macitentan and Flolan, et cetera. That causes the pulmonary vascular resistance to decrease, dilates the pulmonary arteries, cardiac output increases some. So that's the quick and dirty.
Any more questions?
Good. I answered all the questions. That's
Okay.
amazing. Thank you.
Well, thank you very much.
Thank you.